Thank you for the organizers for giving us this chance to present our work that we've worked on in Central African Republic. It's actually a program that is providing community art care in the time of conflict. So I'm going to talk about a little bit about Central African Republic. It has a population of about 4.7 million. There's ongoing, the country has suffered ongoing violence for a prolonged period of time. The active violence actually started in 2013, that actually has resulted into dysfunctional structures in the country, resulting into displacement of the populations. The largest displacement actually happened in the violence that took place in 2017. About 500,000 people have been displaced since the entire duration of the conflict. Armed groups still control, and they are very active. They control most of the mining corridors or the mining areas. So they are quite under the control of the armed groups. In terms of HIV, Central African Republic has an HIV prevalence of about 4%. The highest is among commercial sex workers, which is about 9.2%. And the men who have sex with men have a prevalence of about 6.1%. There are rural areas actually which have a very high prevalence, right? For instance, Hatumbomo, which is in the far east of the country, which is bordering South Sudan, the HIV prevalence is as high as 11.9%. And this is from data of, the DHS data of 2010. So where does CAGS stand in the 1990? 53% of the population population know the HIV status, and 32% are on art, have access to art, and only 8% are accessing antiviral testing. There's a lot of challenges, of course. We'll get back onto that. HIV services are mainly centralized at district levels, so there's still work to do to decentralize services to the lowest point, to the lowest health structures. So the challenges in terms of the national challenges as a country, there's a lot of insecurity. It's very difficult to access most parts of the country. There's very limited resources, financial and human. There's lack of simplified models of HIV treatment. In fact, probably the one I'm presenting is the first of its kind to try and simplify treatment and decentralize to the communities to the lowest level. In terms of the cascade, these factors, these challenges actually impact on the entire cascade from testing to treatment to viral load testing. So the intervention took place in a place called Zemio, which is right in the eastern part, the red region that you saw. It is basically a pilot that we did between MSF and the Ministry of Health. And we actually did two models, which is the pharmacy fast track, which is basically appointing spacing and task shifting and appointment spacing and drug refills for patients who are stable on treatment. And then we also implemented community art groups. This is basically self-forming groups of stable patients who live in a same geographical area that we actually invited to start forming groups. The DSD program is remotely supported at the moment because MSF left the area. And basically we focus on the most important issues to try and maintain the model running, which include drug supplies. We fly drugs in, and now this is done by Ministry of Health in conjunction with Global Fund. So we are trying to actually hand over most of the activities to Ministry of Health and Global Fund. The other challenge has been with transportation of viral load that we try to actually link to these models to make sure that all our patients, we monitor their adherence. We're also setting up a simplified data collection system. So who is in the intervention? The intervention is aiming at all HIV patients in Zemio that are stable and living in a rural and unstable setting. The criteria included all adherent patients that have no opportunistic infections, especially tuberculosis, who actually have a viral load that is suppressed, but viral load was a challenge, so this was not a very strict criteria for us when we were setting up the model. Pregnant women were included and children were also included. So the building blocks in the model, for ART refills, we refill 6 monthly. 6 monthly, and the CAGs actually get their medicines in the community by the help of CAG leaders. The ones in the pharmacy fast track, they actually individually come to pick the medication. The package composes ARVs and cotrimoxazole. Clinical consultations once a year. We offer once a year consultations at Zemio Health Center, which we link with the viral load test. Consultations are done by a nurse or a nurse assistant. And it's basically, it is a package of weight screening, OI treatment, and viral load testing. Psychosocial care is very limited. For CAGs, we try to introduce CAG notebooks that actually they do monthly when they meet in their meetings. So they document and also do a kind of, they also do medication checks. And these are done by the group leader or any member appointed. So in terms of outcomes, we try to look at the data before the intervention and after the intervention. And the cohort before, we looked at the overall retention from the ART start date up to the period before starting of the CAGs, the starting of the model. And the model cohort, cohort after intervention was overall retention from the start of the model up to the end of 2018. So generally, what we saw is in the baseline analysis, the cohort didn't actually do so badly. We saw a retention of about 79%. And after the intervention, we see that CAGs basically have quite a very good retention. And also we see a very low loss to follow up. I must mention that there was a slight bias towards implementing CAGs. CAGs were started, 77 CAGs at the moment, we have at the moment, but 73 of the 77 were started in the period of January 2017 until the end of June 2017, after which we stopped because of active violence. So the patients that were not included in CAGs are actually the ones that we followed as pharmacy fast track. We have some preliminary viral load results, which are very few on 26% of the patients. We've had a lot of challenges with viral load testing. We started in August of 2018 up to around January 2019. And we see again that the CAGs are doing quite better. We see a suppression of about 82% compared to those in PFT. These are patient stories. I'm going to read them very quickly. One patient said that there are many advantages of being in a CAG. The CAG works without, in the CAG, I work without thinking about going to Zemio town. In the CAG, I spend less transport, and in the CAG, I know my brothers who are actually taking the medication. That's a patient from the Democratic Republic of Congo. We are together to share ideas and tips. And the tips, so that's the second patient. I think I've run out of time. Yeah. But this is a very innovative patient that actually started to transport drugs. The next steps is actually MOH. We are supporting MOH to roll out CAGS in the country, and we are actually trying to develop national guidelines to support rolling out these CAGS in those unstable settings. Challenges, we have program challenges, but also ongoing conflict is what has been one of the main concerns for us. We also see now that patients are being displaced in many places beyond Zemio, and we're trying to follow them up, and try to make sure that they get the access to their medication. The other challenges which are specific to DST, ensuring 6 months uninterrupted supply is a challenge. Simplified data collection is also a challenge. Lessons, we've actually seen that CAGS and PFT are feasible and accessible, and we can do them with very minimum supervision.
Thanks, Charles. And I, just in the interest of time, but we are going to have more time for discussion, so I'm sure we'll be able to bring you back and finish some of that up. Thank you.